Welcome to this episode. Today we're diving deep into the complex world of thermal injuries, focusing on burn injuries in pediatric populations and their management. There's a lot to unpack, from epidemiology to emergency care, and even the psychosocial aspects of burn recovery. So let's get started.
Absolutely. Burns are such a multifaceted topic, especially when we consider the unique vulnerabilities of children. It's interesting how burn injuries aren't just about heat. There's cold, chemicals, electricity, and even radiation involved.
Right, and that broad spectrum really shapes how we approach prevention and treatment. But starting with epidemiology, it's notable that while most burns are minor and manageable on an outpatient basis, those involving large total body surface area, TBSA, or critical areas, or affecting very young children or the elderly, often require specialized burn center care.
Yeah, and the data from Canada really highlights that pediatric populations, especially boys under 5, are at the highest risk. The predominance of scalds and contact burns in younger children makes sense given their thinner skin and the fact that most burns happen at home.
Exactly. The thinner skin in young children means they sustain deeper injuries more easily. Plus, their behavior and environment, like spending more time at home, expose them to these risks. And then there's the social determinants. For example, children in rural areas tend to have more flame and contact burns, whereas urban children are more prone to scalds.
That's a crucial point. And when we look at Indigenous children, especially those living on reserves, the risk and mortality rates are even higher. Factors like substandard housing, use of wood stoves, higher smoking rates in homes, underused smoke detectors, and limited emergency response resources all contribute.
It's a stark reminder that burn prevention and care aren't just medical issues. They're deeply tied to social and environmental factors. And over time, Canada has seen a significant reduction in burn injuries, likely due to improved safety programs and treatment protocols.
That's encouraging. But it also means we need to keep pushing on those fronts, especially in vulnerable communities.
Moving on to the characteristics of burn injuries, the extent of tissue destruction depends on several factors. The intensity of the heat source, how long the tissue is exposed, the conductivity of the tissue, and how quickly the skin dissipates heat.
Right, and it's interesting that a brief exposure to a very intense heat source, like a flame, can cause damage similar to a longer exposure to less intense heat, like hot water.
Exactly. That's why severity assessment is so critical. We rely heavily on two parameters: the percentage of TBSA burned and the depth of the burn injury. And for children, using age-appropriate charts to estimate TBSA is essential because their body proportions differ from adults.
And burns covering 10% or more of TBSA in children can be life-threatening if not managed properly. But severity isn't just about size. It also depends on wound location, the child's age and health, the causative agent, respiratory involvement, and any associated injuries.
Absolutely. For example, burns on the face or hands carry more risk due to functional and cosmetic concerns, and respiratory involvement, like inhalation injury, can complicate the clinical picture significantly.
Speaking of types of burns, thermal burns from flames, hot surfaces, or liquids are the most common. But electrical and chemical burns have their own unique mechanisms and risks.
Yes, electrical burns are particularly concerning in young children because they might insert conductive objects into outlets or bite electrical cords. The current travels through the body along paths of least resistance, fluids, blood vessels, nerves, which can cause systemic injury beyond the visible burn.
And skin resistance at the contact point influences the injury pattern. High resistance leads to localized burns, while low resistance can cause more systemic damage, including cardiac arrhythmias and respiratory collapse.
That's why hospital admission criteria for electrical burns include history of loss of consciousness, ECG changes, burns affecting more than 10% TBSA, or the need for monitoring an affected extremity. Cardiac monitoring is standard when ECG changes are present.
Chemical burns are another beast. The severity depends on the chemical type, acid, alkali, or organic, and how long the tissue is exposed. Unlike thermal burns, the injury mechanism is chemical disruption of tissue.
And systemic toxicity is a real concern, especially with eye exposure, ingestion, or inhalation of toxic gases. Continuous flushing with water is critical, but neutralizing agents are contraindicated because they can worsen the injury.
That's a key point. Also, if the chemical is in powder form, water can spread it, so brushing off the powder before flushing is recommended.
Now, when we talk about burn depth classification, the traditional first, second, and third degree terms are still used, but with more emphasis on tissue involvement.
First degree, or superficial burns, affect only the epidermis. They cause minimal tissue damage, the skin barrier remains intact, and systemic effects are rare. These burns heal in about 5 to 10 days without scarring. A mild sunburn is a classic example.
Second-degree burns, or partial thickness burns, involve the epidermis and varying depths of the dermis. They're painful, moist, red, and blistered. Superficial partial thickness burns heal in 2 to 3 weeks with variable scarring, while deep partial thickness burns may take longer and often result in extensive scarring.
And deep partial thickness burns resemble full thickness burns in many respects, but retain sweat glands and hair follicles. They're extremely sensitive to temperature changes, air exposure, and light touch.
Third-degree, or full-thickness burns, destroy the entire epidermis and dermis, extending into subcutaneous tissue. Nerve endings, sweat glands, and hair follicles are destroyed, so the site is insensate. The burn appears dry and leathery, with colors ranging from red to black.
Fourth-degree burns go even deeper, involving muscle, fascia, and bone. The wound looks dull and dry, and you might see exposed ligaments, tendons, or bone.
Clinically, the key difference between third and fourth-degree burns is whether underlying structures like bone or tendon are exposed. That's critical for prognosis and surgical planning.
Definitely. Now, inhalation injury is another major concern, especially in enclosed space fires.
Yes, thermal injury to the upper airway above the vocal cords can cause edema, but heat damage below the cords is rare because inspired air is cooled and reflexes like vocal cord closure protect the lower airway.
Clinical signs include facial burns, singed nasal hairs, and laryngeal edema. But respiratory symptoms like wheezing, hoarseness, crackles, and carbonaceous sputum may be delayed by up to 48 hours.
Carbon monoxide inhalation is particularly dangerous because it binds hemoglobin with much greater affinity than oxygen, leading to tissue hypoxia. Treatment is 100% oxygen administration.
And early intubation is recommended if airway edema is anticipated to prevent obstruction. Waiting too long can make intubation impossible.
Also, full-thickness burns encircling the chest can restrict chest wall movement, making ventilation difficult. Escharotomy may be necessary to relieve this constriction.
Moving into pathophysiology, thermal injuries produce both local and systemic effects related to tissue destruction extent.
Superficial burns cause minimal tissue damage, while partial thickness burns involve significant edema and capillary damage.
In burns exceeding 30% TBSA, systemic responses include increased capillary permeability, leading to plasma protein, fluid, and electrolyte loss.
Edema peaks around 8 to 12 hours in small wounds, but in larger burns, hypovolemia slows edema formation, peaking at 18 to 24 hours.
Anemia can result from direct heat destruction of red blood cells, hemolysis, and trapping in microvascular thrombi.
Initially, there's increased blood flow to vital organs like the heart, brain, and kidneys, with decreased flow to the gastrointestinal tract. Metabolic rate also increases to maintain body heat and meet energy demands.
These systemic changes underscore why fluid resuscitation and metabolic support are so critical in burn care.
Speaking of complications, airway compromise and shock are immediate threats to life.
Infection is the primary complication during healing, both local wound infection and systemic sepsis. Mortality correlates with injury severity and is higher in younger children.
Pulmonary complications include inhalation injury, aspiration pneumonia, bacterial pneumonia, pulmonary edema, embolism, and atelectasis.
ARDS can develop from pulmonary capillary damage and fluid leakage, impairing oxygenation.
Sepsis is a critical concern after the shock phase. Early signs include decreased consciousness and lethargy.
Burn wounds start relatively sterile but rapidly colonize with gram-positive bacteria, mainly Staphylococcus, then shift to gram-negative organisms like Pseudomonas aeruginosa by the 5th day.
Early surgical excision of eschar and autografting reduce sepsis risk significantly.
Now, emergency care begins at the scene. The first priority is stopping the burning process.
For minor burns, cooling with running water is recommended. Ice is contraindicated. Blisters shouldn't be disturbed unless it's a chemical burn. Cover with a clean cloth and remove clothing and jewelry.
For major burns, smothering flames, rolling the victim in a blanket while avoiding head coverage, assessing airway, breathing and circulation, and starting mouth-to-mouth if needed are key steps.
Clothing and jewelry should be removed, wounds covered, and the victim kept warm. Prompt transport to medical aid is essential, with IV fluids and oxygen started as prescribed.
Cooling major burns is contraindicated because it can cause hypothermia and circulatory collapse. Wet dressings also promote vasoconstriction, worsening tissue damage.
Chemical burns require continuous flushing with water. Neutralizing agents are contraindicated because they can cause further injury.
Therapeutic management includes fluid replacement, which is critical in the first 24 hours to counter fluid shifts.
Crystalloid solutions are used initially, with colloids introduced after capillary permeability normalizes. Monitoring urine output, vital signs, capillary refill, and sensorium guides fluid resuscitation.
Children often need fluids exceeding calculated needs due to underestimation of burn size, pulmonary injury, or delayed resuscitation.
Nutrition is another pillar. High-protein, high-calorie diets meet increased metabolic demands. Oral feeding is encouraged unless contraindicated.
Enteral feeding is preferred because it supports gut integrity and reduces bacterial translocation. Parenteral nutrition supplements intake if needed.
Vitamins A, C, and zinc are supplemented early to promote wound healing.
Regarding medications, prophylactic systemic antibiotics aren't recommended. Antibiotics are targeted to identified infections.
Pain management is essential. Short-acting opioids like fentanyl are preferred for procedural pain to avoid oversedation.
Sedation with agents like propofol or nitrous oxide can be used, with continuous monitoring.
Wound management aims to prevent infection, remove devitalized tissue, and promote closure.
Primary excision is performed on full-thickness wounds once the patient is stable. Debridement of partial-thickness wounds requires analgesia.
Hydrotherapy involves daily soaking or showering to remove debris and maintain range of motion.
Topical antimicrobials are applied via various methods: exposure, open, modified, or occlusive dressings.
Agents must be non-toxic, penetrate eschar, and not promote resistance. Silver-based dressings like Acticoat and Aquacel Ag are common examples.
For wound coverage, biological dressings include allografts from human cadavers and xenografts from pigs.
Allografts provide temporary coverage and can remain until donor sites are available, but rejection occurs in 3 to 4 weeks.
Xenografts are replaced every 1 to 3 days and are useful for partial thickness burns, especially on hands and face, allowing pain-free movement and reducing contractures.
Synthetic dressings like BioBrain and calcium alginate mimic skin properties and are used for partial thickness burns and donor sites.
Skin grafts, particularly split-thickness grafts, are used for permanent coverage. Sheet grafts offer better cosmetic results, while mesh grafts cover larger areas but with less aesthetic outcome.
Artificial skin products like Integra promote dermal regeneration and prepare wounds for ultra-thin autografts, speeding healing and reducing scarring, though cost is a limitation.
Cultured epithelial autografts, grown from patient biopsies, offer an unlimited source of skin for extensive burns with limited donor sites.
Nursing care is divided into phases. The acute or emergent phase focuses on shock treatment and airway management, with close monitoring of vitals, urine output, and respiratory status.
Psychological support for the child and family is vital during this stressful time.
The management phase aims to prevent infection, promote wound closure, and control pain and anxiety during procedures.
The rehabilitative phase begins after wound closure, focusing on scar management with pressure garments, splints, and massage, as well as preventing contractures through positioning and physiotherapy.
Psychosocial support continues, addressing anxiety, body image, and family coping, and preparing the child for reintegration into school and community.
Children often regress developmentally, but gain confidence by participating in their care. Families may experience guilt, so family-centered care and consistent communication are essential.
Physical contact and comfort measures remain important, even with extensive injuries.
Behavioral programs may be necessary for non-adherence during rehabilitation.
Prevention remains the best intervention. Education on fire safety, Stop, drop, and roll, and escape plans should start early.
Community programs and burn camps provide support and help prevent burns.
Sunburn prevention is also critical. Broad-spectrum sunscreens with SPF 30 or higher, protective clothing, hats, and sunglasses.
Infants should be kept out of direct sun or physically shaded, with small amounts of sunscreen applied to exposed areas.
Cold injuries like chilblains and frostbite result from cold exposure. Rapid rewarming is recommended for frostbite to minimize tissue damage.
To wrap up, some key clinical pearls. Differentiating third from fourth-degree burns hinges on exposed bone or tendon. Early intubation is crucial in inhalation injury. Avoid cooling major burns to prevent hypothermia. Blister management is nuanced, especially in chemical burns. Fluid resuscitation should be guided by clinical parameters. Early excision and grafting improve outcomes. And psychosocial care is as important as physical care.
Well said. Burn care is truly multidisciplinary and requires attention to detail at every stage, from prevention to rehabilitation.
Thanks for joining this deep dive. Hopefully this discussion adds clarity and depth to your understanding of thermal injuries and their management.
Until next time.